Good afternoon. My name is Ann Wong, and I'm with the Illinois Chapter American Academy of Pediatrics, and I thank you for joining us for today's webinar for National Infant Immunization Week. Today we are joined by Dr. Mark Sawyer from the Rady Children's Hospital in San Diego and UCSD School of Medicine. Before we begin, I'd like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Dr. Sawyer will answer them at the end of the presentation. Everyone will receive a copy of the PowerPoint slides, a link to complete the webinar evaluation, and a link to the recording of the webinar by the end of business day tomorrow. Dr. Sawyer is a professor of clinical pediatrics and a pediatric infectious disease specialist who at the UCSD School of Medicine and Rady Children's Hospital, San Diego. He is the medical director of the UCSD San Diego Immunization Partnership, a contract with the San Diego County Agency for Health and Human Services to improve immunization delivery in San Diego. He is a current member of the American Academy of Pediatrics Committee on Infectious Diseases and the FDA Vaccines and Related Biological Products Advisory Committee. Dr. Sawyer is a past member of the CDC Advisory Committee on Immunization Practices. He is engaged in projects in San Diego and California to increase communication with the community on the subject of vaccine hesitancy and to develop a curriculum for primary care residents to teach elements of vaccine safety and vaccine safety communication. His 3 children are fully immunized. Please join me in welcoming Dr. Sawyer. Okay, Dr. Sawyer, I'm now going to switch the presentation over to you, and you can begin whenever you are ready.
Thank you very much, Ann. It's great to join you as part of your National Infant Immunization activities this week. And it's nice to get shifted to Central Daylight Time because I'm actually on my way to Chicago later today for a Committee on Infectious Disease meeting at the Academy. So this is perfect. So Ann asked me to give an update on vaccines for young children, consistent with the theme of Infant Immunization Week. And although we don't have any brand new vaccines for children, there have actually been a surprising number of new recommendations and small adjustments to the recommendations for the existing vaccines. So I'm going to try to cover those. And it's getting a little bit confusing, and I'm going to illustrate that by some of the what I consider confusing points, which I then hope to address during the rest of this presentation. So, for example, we used to require 3 repeat doses of hepatitis B vaccine for the young infants who didn't respond to their first doses when that was important. In other words, babies born to mothers who are carriers. And now there's a new recommendation that says we may only need 1 dose, and I will go through that. We used to promote the live attenuated nasal flu vaccine, FluMist, and now we're not using it at all. What happened with that? MMR vaccine is a 2-dose vaccine, so why are, in some circumstances, is it being given as a 3-dose vaccine? And I will go through that. I think by far the most confusing thing in vaccines these days for children are the meningococcal vaccines, the ACWY vaccine versus the meningococcal B vaccines, one of which is routinely recommended for a small subset of infants and routinely for adolescents, but the other one is not. So we will go through that. And although this isn't new, there's 2 different kinds of pneumococcal vaccines. Some children need one, some need the other, and some need both. So it is a confusing landscape regarding immunization. So I'm going to hopefully address all these things, and my specific objectives for you. At the end of this presentation, I'm hoping you're going to be able to explain why the birth dose of hepatitis B vaccine is now supposed to be given within 24 hours of birth to all babies, because that's a new recommendation, and we're going to have to work with our birth hospitals to get that instituted. Describe the new options for repeat hepatitis B immunization of infants who don't respond to the first 3 doses, so that you can decide which of 2 approaches you want to follow. I'm going to, hopefully at the end of today, you'll be able to explain why the attenuated nasal vaccine for influenza is not being used, so that you can explain that to your 5-year-old patients who are very upset with this change in recommendation. I'm hoping you're going to continue to be able to strongly advocate for pregnancy Tdap immunization, which is our best strategy to protect infants from pertussis. Describe why a 3rd dose of MMR vaccine is sometimes being given, so that you're prepared to give it if that recommendation comes to you. Distinguish between the 2 types of meningococcal vaccines, and remember which one is selected infants are required to receive. And then, most importantly, perhaps know where to go quickly to figure out which children need the pneumococcal polysaccharide or PPSV23 vaccine on top of their Prevnar, because that set of recommendations is particularly confusing. So a lot of information packed into this session. We will have time for questions and comments at the end. So let me start right off with hepatitis B. I mean, what can possibly be new with hepatitis B? We've had the same vaccine for hepatitis for 30 years now. I do want to remind you that hepatitis B chronic infection is still very prevalent across the world, and we have immigrants coming from many parts of the world on a regular basis who are already infected with hepatitis B. And also remind you why this is such a problem for us as pediatricians, and that is when chronic hepatitis B infection occurs, if babies are infected, usually at the time of birth, 90% of them go on to have chronic infection. So resolution of hepatitis B infection acquired at birth is quite rare. As you get older, fewer and fewer individuals become chronically infected, which is good. So for infants, though, it's the vast majority become chronically infected, and those who become chronically infected have a risk of premature death from cirrhosis or hepatic carcinoma. So this is why hepatitis B continues to be a problem, a combination of increasing or continued immigration of people with chronic infection and the high stakes for young infants. As a result of this situation, the CDC for many years has been running the perinatal hepatitis B prevention program, working together with local and state public health to track babies who are born to mothers who are chronic hepatitis B carriers. And this is a summary of that program from 2014. And as you can see, we're talking a lot of babies here, 11,000 babies enrolled into that program in just 1 year. And in fact, if you look at the prevalence rates for hepatitis B, the CDC actually thinks there are more babies out there that we're not capturing. So this is a significant problem. The good news is the vast majority of these babies are getting appropriately immunized at birth, 97%, but that leaves 3% who are not, and those are the babies who are at significantly increased risk to get chronic infection. In terms of completing the whole vaccine series, we're not doing as well. Only 74% have received all 3 doses of vaccine by 8 months of age. We're doing even less well with post-vaccine serologic testing, PVST, which is supposed to follow the 3-dose series for babies born to infected mothers, and only about 2/3 of babies are being tested. So we really don't know how many babies are not responding. Among those who are tested, however, 2% need revaccination. So if they're not revaccinated, they remain at continued risk for hepatitis B transmission through just close contact within families, which is well documented to